Hey, everybody. So this in-service is going to be what I call Hospice 101. So I'm going to give you an overview, history of hospice, the philosophy, what kinds of things that we do, what's covered, what's not covered, etc. So let me share my screen and let's get to it. Okay. And let's make that go away. All right, overview to hospice care and services. So the learning objectives are going to be that you'll be able to describe the hospice philosophy of care. You'll understand the history of hospice. You'll be able to identify and name the services that are available under the Medicare hospice benefit. You'll understand and define the concept of IDG or interdisciplinary care. You'll describe the importance and the role of each hospice team member. We'll talk about DNR, DNI, DNH, POLST, advanced directives, living will, and durable power of attorney as they relate to hospice. And then also understand the conditions of participation as they apply to the delivery of hospice care. So let's start out with what is hospice? It's a concept, right? It's not a place or a building or any institution. It's a team that works together to provide holistic end-of-life care for terminally ill people and their family members, even after the patient's death. And hospice focuses on providing comfort when a cure is no longer possible. So the philosophy of hospice, we affirm life. We offer palliative or, palliation, not curative care. We understand and we help educate so that people understand that dying is a normal part of living. Grief is a normal response to loss. There's nothing wrong with grieving. We expect that to happen when you lose someone you love. We really emphasize pain and symptom control. And we don't just care for the family, we care for the family unit. So, all of them. Through the course of history, pre-Christian era, death was part of the life course and it was kind of a community event. As religion got to be more and more a part of people's lives, like in the Middle Ages, people went to religious shrines to seek cures. They thought, miracles could happen. And throughout history, in almost every culture, mourning was evident in the way people dressed, funeral activities that were held. Oftentimes houses were marked when someone died. I know when I was a kid in South Philadelphia, they would have a funeral with a viewing. They called it the wake, and that would be at the person's house for sometimes 3 days. The coffin would sit in the living room. So, that was fun. In the 19th century, we had increased medical knowledge. We started learning more things, and that led to medicalizing the dying process, right? So after World War II, we started, and I'm not sure if this was great or not, but doctors are trained to think that if you lose your patient, death is a failure. And I mean, it's really not, because there sometimes is nothing that you can do. In the 1960s, Dame Cicely Saunders began a hospice in London, England. It was St. Christopher's Hospice. For those of you watching this that are nurses, I'm sure you've all heard about Dr. Kubler-Ross, who wrote on death and dying and basically broke down the stages of dying into what we call DABDA: denial, anger, bargaining, depression, and acceptance. And, people really do go through these phases. Imagine if someone told you you had 6 months to live. So the first American hospice was in 1974 in New Haven, Connecticut, Hospice Inc. Isn't that funny? And then local hospices started popping up in the US, and they were mostly volunteer programs. And those volunteer programs were so successful that it was the impetus for Medicare to come up with the hospice benefit. So in 1983, Medicare added hospice as an option, not a requirement, but an option under Medicare Part A. And the bill included what's called a sunset provision through September 30th of 86. What that means is they would evaluate it, see if was it cost effective, was it successful, and should they continue it. And that was the first time since 1978, when the end-stage renal disease program was initiated, that any Medicare benefits expanded in 1983 with that Medicare hospice benefit. So what is the hospice benefit? When a patient signs that election of benefit, that EOB, what they're doing is they're waiving the rights to other Medicare benefits. And we, as the hospice, are providing everything that's relative to the care of that terminal illness or illnesses. So a patient that's new to hospice would have 2 90-day benefit periods. right? Subsequent to each other. And after that, the third through unlimited benefit periods are 60-day periods, and they require a face-to-face patient encounter either with a nurse practitioner or a physician to attest to the patient's terminal state, okay? The prognosis is what determines eligibility. And the only person who can prognosticate is a doctor. Can be a DO, can be an MD, okay? The location of care for routine home care, it's in their home, right? At least 80% of the time. So home is defined as where they live. And it can be a home, like a single family home or an apartment. It can be an assisted living facility. It can be a SNF. And one of the things that's always kind of confusing is what's related and what's unrelated, related versus unrelated services. So what does that mean? When we talk about related versus unrelated services, I'm trying to get this out of our way. Let's say a patient is admitted and they're admitted for cancer, okay? And it's pancreatic cancer. When we think about things that comorbidities or other diagnoses that would be related to the pancreatic cancer, think about, well, maybe diabetes, right? We are responsible to care for the patient, including services and drugs and any other care required for all the related diagnoses to the terminal diagnosis or the terminal illness. And that often gets hairy. So that's something that really should be determined by the physician, not by nursing. And if there's question, it can always be discussed at IDG. So we shouldn't just arbitrarily decide what's covered and what's not covered, or what's related and what's not related, because it's very complicated. Oops. Okay. So the unit of care, the hospice unit of care, it includes the IDG team or the IDT team is in the middle, right? And that includes all the branches, which are spiritual, psychosocial, medical, bereavement, and the patient and family, right? All of these things work together to form that IDT, that interdisciplinary team. So the hospice benefit, as defined by Medicare, terminal illness or illnesses with a physician certified prognosis of 6 months or less if the disease runs its normal course. And that's not an exact science. I want to add, prognostication is not an exact science. And sometimes people live longer than 6 months, you know? So it's something to remember. Palliative care symptom management is what we do. No curative or aggressive treatment. And the patient would have to sign the consent for care. We provide services 24 hours a day, 7 days a week, and the core services have to be provided by staff that are employed by the hospice. Core services are the medical director, physician, nursing, medical social worker, and then the counseling team, which is spiritual and bereavement. And they, all of us, right, that whole team is responsible for the oversight of the plan of care. What are we doing for that patient? Non-core services are things like their medical equipment, you know, DME, medical appliances, any other supplies, you know, briefs, those kinds of things, drugs, pharmaceuticals for pain or symptom management. Hospice aides and homemakers are considered non-core services. And I want to just clarify something that's a common misconception. I hear people say the aide can go for 1 hour a day, or the aide can go for 2 hours a day. It is not like that. The aide can go to follow the plan of care that is developed with the patient, their family, and the nurse for whatever time it takes to provide the care that is specified in that plan of care. So if it takes 40 minutes, it takes 40 minutes. If it takes an hour, it takes an hour. If it takes 2 hours, it takes 2 hours. But there's no time frame or limitation associated with it. And then also volunteer services and ancillary things like massage, sometimes music therapy, sometimes pet therapy are included. And we don't get reimbursed for any of that. There are levels of hospice care: routine home care, continuous care, respite care, and GIP, which is general inpatient care. So let me explain what they are. Routine home care, that's the most common. And that's where we're providing intermittent visits based on whatever that patient and family need. The core team, remember, the doctor, the nurse, social worker, spiritual, we provide the services needed in the patient's home, and we're on call 24/7. Continuous care. Continuous care is for periods of crisis. If the patient is having symptoms that require a nurse or someone else to be there, symptoms that are out of control. We can provide CC, continuous care, for 8 to 24 hours a day. 51% of the total care should be nursing. 49% can be an aide. And we have to document hourly. And this is something that can be used in the last days of life when their symptoms maybe are out of control and, can't be managed by the family for whatever reason. Respite care. We will contract with all the skilled nursing facilities for a bed for a 5-day stay. And that can be provided one time during a benefit period or even, under an emergency situation. And it relieves the family of caregiving temporarily. So the patient would go transported into a skilled nursing facility. There's still our responsibility. The standard nursing home admission procedures aren't required. We just send over med list and, face sheet and the plan of care. We coordinate the care and we still have our 24/7, responsibility. And we pay the bills to the facility on a per diem basis. Then there's inpatient care. We can contract with a hospital or a skilled nursing facility with a subacute wing for a short-term admission, GIP, usually 1 to 3 days. It's usually 1 day or less. And the goal is to control acute symptoms or pain. And it's for really difficult cases. Palliative care only. We still coordinate the care. We still provide the on-call 24/7, and we pay the hospital to keep the patient in that bed. That's under extreme circumstances. Hospice in a nursing facility. In 1990, they expanded the benefit to include hospice to be provided in a nursing facility. Nursing facilities, 1 in 4 nursing home residents have pain for 2 or more months without any appropriate management. So there's got to be a contract between the facility and us. Hospice and skilled nursing facility have to coordinate the plan of care. Hospice services for the patients in a facility look the same as the care in a home setting. We pay for the care. So the hospice services are covered under the Medicare benefit. And then the room and board gets reimbursed to hospice at 95% of the rate. And we pass through the reimbursement to the skilled nursing facility, but we pay them 100% of the room and board. Okay, so we lose 5%, but that's okay. Bereavement. Bereavement is required by CMS. We don't get reimbursed for it. We are required to provide 13 months following the patient's death. We focus on preventative health care for the bereaved, services to the family, skilled nursing facility staff if they were involved, and anybody else involved. And that includes individual counseling, support, telephone follow-up, written follow-up, support groups, memorial services. It's important that the patient's families know that we're there for them for a full 13 months after that patient passes. Top hospice diagnoses, 37% are cancer. These are old stats, and I have the feeling that these have changed a little bit, but just to kind of give you a broad overview, usually the reasons why people come on hospice are cancer, heart disease, some type of dementia, other ALS, neurological, HIV, those kinds of things, lung disease, stroke or coma, kidney, and then liver. Rights, responsibilities, and advanced directives. So patients have rights and responsibilities. We give them that packet upon admission to hospice, that initial visit. So in that patient information booklet, it basically goes over their rights and responsibilities. And we have to review them with the patient, and we have to do it in a way that they understand. If they can't read, we're supposed to read it to them. If they have other communication issues, they're deaf or they don't speak English, we have to make sure they understand. We have a language line, and that language line is there for non-English speaking patients. There are thousands of languages. So all you have to do is call that number and you have that available to you 24/7. HIPAA, everybody knows HIPAA. So we have to give them their information on HIPAA. All their protected health information is kept confidential, and that includes anything spoken, written, printed, or electronic. We don't talk to anyone about a patient except those on a need-to-know basis. And we only share information when it's necessary for treatment, payment, or the operation of agency to provide care. Right? Informed consent. Hospice patients have the right to make decisions about their care and treatment within reason. If the patient wants a bath in ice cubes 5 times a day, we as the nurse will explain why that's not a good idea, and we vow to do no harm, so we will not do that. But they should be an active participant in their plan of care. We give them their information about rights and responsibilities, and we also give them information about what hospice is and our policies and philosophy of care. Incapacity. If someone is deemed incapacitated, that means they can't make their wishes known and they can't make decisions. They could be in a coma, near death, or tunded severely ill. If they don't have a POA or a next of kin, the court will delegate a guardian to them, a legal representative, to make decisions for them. Advanced directives. I have advanced directives. We should all have them. It's a written document that tells everybody what you want. And that includes a living will, and a durable medical power of attorney, which is also called a healthcare surrogate or medical or healthcare proxy. So the living will is the written instruction, and the durable medical power of attorney, blah, blah, blah. That is the person that you designate to speak for you if you can't speak for yourself. So the living will goes into specifics about artificial hydration, tube feedings, respirators, ventilators, pain meds, heroic measures like CPR, dialysis, all those things. Are you an organ donor? Any funeral or burial instructions that you may have pre-planned would be included in that. And the durable power of attorney for healthcare, it's the person that they're naming, that's the proxy that stands in their place to make their wishes known and to make decisions. State specific, but that's generally legal in all 50 states in the country. And there are lots of names for it. So it's not a general power of attorney. It's a durable medical power of attorney or healthcare proxy. General power of attorney is about money, finances, right? So that names a legal representative who can sign their checks and pay their mortgage, et cetera, right? That's different. We're not really concerned with that. And then we have a post, last but not least. And the post, this is a New Jersey post. It needs to be reviewed with a physician, but it doesn't mean that the patient can't fill it out and then review it with the physician and sign it at that point. But we can certainly present it and introduce it to patients and family members so that they can start to have that open discussion. Talking about things doesn't make them happen. And it's better to have a plan in place. I could leave here and get struck by a truck, and that could be all she wrote. I want to make sure everyone knows what I want and what I don't want. So I hope that gave you a good overview. There's more to come. So that's it for now. And until next time, see ya. Stop the share, and I am out.